Hello to everybody, my name is Juan Felipe Abaunza-Camacho. I'm assistant physician and epidemiologist of Neurosurgery department at Samaritana University Hospital in Bogota, Colombia. Thank you for this opportunity. Today I'm going to present one of our study called Transient Third Cranial Nerve Palsy after pipeline shield treatment of a ruptured anterior cerebral artery dissecting aneurysm. All we know that the intracranial dissecting aneurysm is about the 30% of all intracranial aneurysms, usually at the posterior circulation. The subarachnoid hemorrhage is a frequently presented pattern of this pathology, but usually is not related to the third cranial nerve palsies, as in our case. The endovascular therapy has proved to be a successful treatment with a high occlusion and low morbidity and mortality rate. For that reason, in our study, we decided to make a retrospective review of the cerebrovascular registry at an academic institution in Bogota, Colombia, particularly in Samaritana University Hospital. We identified patients who present with ruptured dissecting aneurysms treated with flow diverting devices between January of 2019 and December of 2020. As the results of this study, we documented only one patient that presents all the inclusion criteria. Is a male with middle age that presents headache with altered state of consciousness after a sexual intercourse. For that reason, we decided to make a CT consider the red flag symptom associated with the headache. The left side of the window we can see an axial view of a head CT that relates a frontoparietal subarachnoid hemorrhage related to the black arrowhead and a hyperdensity related to the white arrow related to the proximal segment of A1 of the left anterior cerebral artery. In the other side of the window we can see an oblique view of a head CTA with a 3D reconstruction that showed a proximal stenosis selected with a white arrowhead and a post-stenotic dilatation that is selected with a white arrow. Here we got an anterior-posterior projection of a digital subtraction angiography that show us a dilatation associated with the A1 segment. Here is a lateral projection of the same angiography that confirms that we are related to a ruptured intracranial dissecting aneurysm that is showed with a white arrow. In this case, a decision was made to proceed with urgent endovascular treatment of the aneurysm. The patient received loading doses of dual antiplatelet therapies for 48 hours, then was taken to the neuroangiography suite. After induction of general anesthesia, an intraoperative infusion of tirofiban was initiated, and then a pipeline flex embolization device with child technology was deployed at the A1 segment of the left anterior cerebral artery. Here we got an anterior-posterior projection of the post-procedural angiography that showed an adequate permeability of the flow diversion device. In the next 12 hours of postoperative, we documented a third cranial nerve palsy, included an mild left eye ptosis, a non-reactive dilated left pupil, left superior and medial inferior recti and inferior oblique muscles paresis. We made a CT that discarded strokes that explain the symptoms. For that reason, we decided to start dexamethasone, and the patient started to recover in the last few days. In 1 month follow-up, we got this cerebral detail subtraction angiography in anterior-posterior projection that showed adequate flow in the flow diverter device. In conclusion, we can affirm that this is the first documented case of flat transient isolated incomplete third cranial nerve palsy after successful pipeline shield treatment of an anterior cerebral artery without evidence of a periprocedural hemorrhagic or ischemic event. We can explain this as an inflammatory response generated by the flow diversion device, or hemotoxicity associated with subarachnoid hemorrhage. However, this needs to get more investigated.